Good afternoon, and thank the organizers for inviting me. So today I'll be debating against what Dr. David Ritchie has been saying, but I want to make two clarifications. One is there is no confusion in my mind that there should be an allogeneic transplantation for patients with high risk MDS and patients with AML and early relapse. And second, this is not a debate about induction chemotherapy of Ara-C versus no induction chemotherapy. It is any form of cytoreductive therapy prior to transplant which is going to try and improve outcomes post-transplantation. So my stance is no. I also want to say that I take a point somewhere in between, but for argument's sake, I'm taking an extreme point of view to make this debate and to stand by the data. And I try to present to you a little bit of data. I'll start with this. I want to say that these are two very unfair representations. One is both are basically newly diagnosed AML. That's the outcome in one group, and this is the outcome in another group of patients. Just looking at this data, you would go by the 60%, right, in terms of treatment outcomes. But then you look at the background to this. This is 325 patients randomized into the 45 versus 90 milligrams, multiple centers, truly reflective of what is happening in the world in terms of AML, induction, and about 10% received transplant. While this is a single-center data from Kolb et al. In Germany, giving you a 60% survival with primary induction failure who received chemotherapy in cytopenia, received a reduced intensity transplant, and have a 60% survival. Nobody is talking today about taking a newly diagnosed AML, giving him Flamsa regimen, doing a reduced intensity conditioning transplantation, and saying, forget about all this multiple cycles of consolidation chemotherapy. This is the approach to take for AML. Nobody says that, and even if you don't understand statistics in great depth, you can clearly understand that the strength of this analysis is much more than this single center with all its biases. And there is a problem. The way current publication practices may distort science, this is not my thing, this is an article by Dr. Neil Young, and he talks about how there is a tendency when somebody publishes, so for example, Kolb et al. Publishes a 60% figure of primary induction failure. Now, my center, we have a less than 10% chance of patients surviving. What is the probability that I or anybody else in this audience who has similar data is going to see that data published? Very, very unlikely. So there is a phenomenon of, it's called the winner's curse in a sense, that a certain person publishes, and then subsequently everybody tries to follow the leader, and that's called herding. I think this is an interesting article, and whenever you deal with disease with small numbers, you tend to see this phenomenon. So you often get this, your manuscript is thoughtful and well-written, however, we are looking for stuff in the shock and awe genre. So it's often difficult to publish negative data when somebody has set certain bars very high. Now, putting that aside, I'm going to discuss the topic today under these three broad headlines. What is the impact of residual disease prior to allogeneic stem cell transplant on outcome? The second point is it feasible to get MRD negative or complete remission prior to transplant in this group of myelodysplastic syndromes, high-risk myelodysplastic syndromes, and early AML relapse? And finally, what is the role of novel approaches to consider to achieve the above goal? Now, the impact of residual disease prior transplant has been addressed very well in the literature, and it's a recurring thing in hematological malignancies. All of us recognize it, those who are in the transplant field or deal with hematological malignancies. In the setting of autologous transplant, clearly PET-negative patients do better. If you have relapsed APML, you want to achieve molecular remission before you do an autologous transplant. Otherwise, you know your outcome is bad. The argument will be in the setting of an allogeneic, it's not that important. The graft versus leukemia is what is really the most important factor. But in truth, you take any disease, and here I've just taken ALL as an example. You can find the same data in the context of Philadelphia positive leukemia, MLL leukemia. In this relapsed group of patients with ALL, in this BFM group, they're clearly showing these are all patients who are in hematological remission. But just by looking at the molecular level MRD positivity prior to transplant has a huge impact on outcome. So patients who have no MRD detectable, relapsed ALL, received this chemotherapy regimen, MRD negative, have a very good outcome post-transplant. And not only is it positive and negative correlation, also there's the biological gradient, which makes it statistically much more significant. That means the greater the degree of minimal residual disease you have, the more likely that you will relapse post-transplant. This is data which goes more than a decade earlier. People have already shown this data. And similar type of data, not talking about hematological remission, I'm talking about patients who are in complete remission but have MRD detectable by whatever molecular tools, has an adverse impact on outcome post-transplantation. Now, let's take AML, which is closer to what we are looking at. This is a publication, this I think is a publication from MD Anderson, actually. Impact of pre-transplant MRD in AML. Again, I want to stress, these are patients prior to transplant, all patients who are in complete hematological remission. But by looking at MRD on a flow cytometer, where MRD is defined as greater than 0.01% in this analysis, in spite of the fact that they're in complete hematologic remission, if you have MRD by this very sensitive assay, you have a dramatically difference in outcome in terms of whether you will have a successful transplant in terms of long-term survival or not. And the poor outcome in the group that had MRD is essentially related to relapse. So if you went in for transplant with AML and you had MRD positive, there is a very high probability that you will relapse. Moving to MDS, and Dr. Simrat and colleagues have put together a number of reviews on this. There are a number of articles which have looked at this, and Dr. Ritchie has already gone through some of them. But I want to go through some of them in a little bit more detail. I'm going to address a few of them. It's not possible due to the constraints of time to go through all this. The first paper that I'd like is a paper that actually comes from the Minnesota group. Again, these are all the criticisms and limitations that I point out. Small number of patients, fairly diverse group in terms of classification. The people who actually got treatment in terms of induction chemotherapy were actually very small, and the people who achieved CR were also very small. So in spite of all this, clearly patients who were in CR, and I take the fact that these are huge selection biases in these kind of data, but those who are in CR definitely do better than those who are not in CR. And the conclusion of this paper was blast percentage less than 5% at hematopoietic stem cell transplant is a major predictor of disease-free survival. Myeloablative conditioning is associated with low relapse. Non-myeloablative conditioning yields similar results when the blasts are less than 5%. But a myeloablative conditioning is not able to overcome when you have greater than 5% blasts, at least in this particular analysis. The second paper that I want to point out is the paper that was actually Dr. Ritchie has already pointed out, and this paper is essentially from the Sloan Kettering group, I think. And this is a little confusing in the sense that the type of transplant conditioning, there's T-cell depletion, etc. But again, small number of patients, fairly heterogeneous group, and the type of treatment that was given was high-dose intensive chemotherapy with anthracycline and standard dose cytosine 53%. But what's important is that what I think is important is that of 33 patients, almost 2/3 of them could achieve a hematological remission in this group of patients. Again, I can see that there is a fair amount of selection bias. But 2/3 of those patients, even if you can identify the factors which made these patients candidates for receive induction chemotherapy and achieve CR, did much better than patients who did not achieve CR. And this is a survival curve that Dr. Ritchie had already pointed to you. And all the points that he said are all valid, but I would argue that it would be interesting to identify patients who are in this group and see what were the parameters that favored them to actually overcome, and then consistently apply this phenomenon of induction chemotherapy in that group of patients, rather than say this is a phenomenon seen in a few patients. Now, this is a paper that Dr. Ritchie had pointed out, saying that this is a paper from the I think this is from Fred Hutchison. This is Joachim Dieg. And here, basically, this is a negative paper, said the impact of chemotherapy did not make any effect on outcome. Again, small number of patients who got induction chemotherapy were 33, and those who did not get induction chemotherapy were 92. And the survival curves were very similar. The type of chemotherapy given, for the most part, was a conventional anthracycline cytosine. But what I want to point out is one of the tables over here, and what Dr. Ritchie didn't tell you was 73% of the patients in the arm that did get chemotherapy were actually AML, compared to a very small fraction in the group that actually did not get chemotherapy. Were only 8 of them, 8 of the 92 in the group that did not get chemotherapy were actually transformed to AML. So clearly, you already have a very heterogeneous group, and then you get results that are kind of comparable. Now, this is another paper, which is a Japanese paper that Dr. Ritchie again referred to, and showed that giving chemotherapy prior to transplant did not have an adverse impact. And I agree that this paper is statistically very sound, but I just want to point out a few facts over here. One is that Dr. Ritchie didn't actually give you the numbers. And the details of chemotherapy are as follows. No chemotherapy was 28 people. Of those who received chemotherapy and achieved CR was 43 out of 68. And those people clearly did much better than those who did not have a response after chemotherapy. A cautious interpretation would be that there was an exceptionally good outcome in the series of 28 patients without chemotherapy. And that really skews this is much better than reported in most patients. This is almost like 60% of patients who had high-risk MDS who had a very good outcome. So the small number of patients from a single center with a very good outcome really skews this analysis in a particular direction. Now, is it feasible to get MRD negative or CR prior to transplant? And both Dr. Champlin and Dr. Ritchie have pointed out that there are many approaches being used, azacitidine and hypermethylating agents. And I think these are things that need to be evaluated. These are two very early studies. Basically, what they say is that it is possible to use these agents effectively prior to transplant. And in patients who are able to reduce the risk or the number of blasts, the outcome, at least in this early data, seems to be better. So I hope I've kind of made the following points, that the impact of residual disease prior to allogeneic stem cell transplant outcome is overall consistently poor. Doesn't matter which disease model you take in hematological malignancies. Is it feasible to get MRD negative or CR prior to transplants? I think it is possible. I also concede that it may come at a price, and therefore the challenge will be to individualize and identify cases or young patients with no comorbidities, for example, who you may want to try and achieve some kind of a response before you take them up for allogeneic transplant to give them the best possible chance of achieving a long-term cure. And novel approaches to consider to achieve the above goal are evolving, and I think we should encourage such studies. It is difficult if we believe that we already have the solution and we should transplant every patient as soon as we diagnose early MDS. I think a proportion of patients would definitely benefit. The challenge is to identify which subset will actually benefit with this approach. Thank you for your attention.
So we'd invite you to come over here, and then we can have discussion. Any questions from the audience? Please go to the microphone. Swami?
Very elegant talks. I should say that you can always look for a smiling face if you have your eye for it. But Dr. Mathews, question. One of the issues with minimal residual disease in myeloid malignancies is it's a conundrum in itself. It's been the search for the right parameter to look for a minimal residual disease. I think that's one of the caveats for getting to cytoreduce these patients. And there's even a paper saying that AML, when it comes to MRD, is not equal to ALL in terms of MRD. So I think all this data is flawed, and we think that you're absolutely right. When we have the right agent, we'll be able to do it. But what are your thoughts on that MRD itself and assessments?
I agree. MRD is a difficult point in terms of AML. It depends on the sensitivity. In fact, if you have a test which is very sensitive, it becomes less discriminative. So to get the optimal kind of test which can predict. But having said that, a lot of the data out there with AML, for example, is fairly reproducible, especially by flow cytometer. But I agree, for example, in the APML area, I can speak with a bit more confidence. If you start taking tests which have sensitivity of 1 in 10 to the power of 6, for example, which you can do by modifying your RT-PCR and RT-PCR settings, you lose the discriminatory ability to predict relapse. But I think the bigger point that I was trying to make was that achieving what you want to define as MRD, but as low a disease load as possible, has a beneficial effect on allogeneic stem cell transplantation in terms of outcome. And I think in many disease models, lymphoid and myeloid, that seems to be a consistent theme.
Yeah, so it stands to reason the more disease you have, the more likely you are to relapse. So people who are MRD negative you would expect would have lower relapses than people who are MRD positive. But obviously, it's the differential effect. Can you cure them with standard chemotherapy, or do you need a transplant? The MRD positive ones are likely going to relapse and die with standard chemotherapy. The transplant, will cure some of those patients, but they will have a higher relapse rate than people who are MRD negative. So, go ahead.
Vikram, very convincing arguments, compliments for your presentation. Considering the population for most of these hematological malignancies in Asian countries is very young. And so therefore the incidence of myelodysplastic syndrome may not be as high as in the Western world, but we do have a good population. And considering the fact that many of the patients, they reach quite late to the transplant centers. So you will have a more proportion of high-risk patients of MDS, even in the Asian country, even they are young. So considering the economics of transplant, economics of trying these hypomethylating agents and all that, would you not like to consider doing transplant in these patients in the first go rather than trying the chemotherapy or other things?
So I think even though we've taken diametrically opposing views and argued different points using exactly the same data, I don't think this is an either-or discussion. I think this is how to get your patient to transplant.
Sure.
The first decision, should we transplant these patients? Absolutely yes. And then the next decision is how best to get them to that point. I mean, clearly the truth is somewhere between. There are patients where the next best thing you could do is condition them and transplant them, and there are patients where the next best thing you can do is attempt to get their disease under some form of control. No one would argue that the unwell, cytopenic, high blast count marrow patient needs some disease control in order to benefit from transplant in most instances. I think one of the interesting things which we haven't actually talked about today is the effect of going to transplant with a burden of disease as a factor for the complications of transplantation. And we know that in many other instances, for example, CLL, going into transplant with a burden of disease enhances the likelihood that you'll have transplant-related complications, which may or may not be fatal. But that's one of the things that goes through my mind when I'm thinking about transplanting someone with early relapse or MDS, is how burdened are they by their disease?
And so, the original Seattle paper that you had shown, where a lot of those patients were people who, if you will, they relapsed on the airplane. They were felt to be in remission, but when they arrived in Seattle, they were not in remission, and they just went ahead and did their transplant. So those people had early relapse, if you will. And those patients are very different than the patient that you referred to, somebody who's got 50,000 blasts in the peripheral blood. And when we look at our own data at MD Anderson, people that do not have circulating blasts, just have leukemia in the bone marrow, have an intermediate prognosis, sort of halfway between overt relapse and people in remission. So there's people in relapse is a spectrum of disease from 6% blasts, the definition of leukemia and florid relapse.
So I actually agree with Dr. Mathews that the low tumor burden for stem cell transplant, especially in risk conditioning regimen, is better than the high tumor burden. And I want to ask all of you that if you have the young patients about 33 to 40 years old that in advanced MDS and blast in the bone marrow about 15%, and he have the massive brain donor, and I have the three choice for you. First, you will go on to stem cell transplantation with myeloablative regimen, and second choice is you will induction patient with something just like azacitidine or anything to get low tumor burden in the bone marrow and go on reduced intensity conditioning regimen. And three, you will go to the stem cell transplant and do the reduced intensity regimen and follow chimerism, MRD, and if he relapse, you will get about DLI or anything for all of you.
Okay, it's a lot of questions there. So you present a young person with refractory anemia and excess blasts who has a matched sibling donor. And so in the US, we're actually debating how best to set up a national study to look at transplant versus non-transplant therapies for MDS. And so the question is, should we give all patients a hypomethylating agent like azacitidine, and for how many courses before doing a transplant? And this is something that's unsettled, and there's wide opinions among the professionals involved. Some have advocated giving 4 cycles of azacitidine to try to achieve an optimal response. Other people argue to directly go to transplant, and there just isn't data right now, I don't believe, to answer that question. Any comments?
What I would do is 1. What I'd like to do is 3. So what I would do is that in that patient came to me now, I would take them straight to transplant from an HLA identical sibling, and probably from an unrelated donor as well. And what I would like to do is to ask a wider question, which is what Richard's just said, which is utilize post-transplant disease-modifying agents, follow their 34 chimerism, and intervene if they show evidence of imminent relapse. But that's a complex study and one which we hope to participate in.
And use reduced intensity regimen as conditioning regimen.
I'd like to do that study too.
Yeah, so the patient you mentioned was 38. How old was the patient?
38.
38. So at least in our hands, we would give that patient our myeloablative regimen, and we had actually done a randomized study looking at busulfan levels, and giving high-dose busulfan using pharmacokinetic dose adjustment actually in people with overt MDS led to improvement in their progression-free survival. So if it's a young patient, I would give them an ablative regimen. If they're over the age of 60, then I would not.
Thank you.
Other questions?
I just wanted to jump in and say that in terms of the induction treatment, now there are some excellent data with frontline combinations with Vidaza and lenalidomide, and with varying doses of lenalidomide from 25 milligrams to even 50 milligrams in the leukemia. Those patients are able to tolerate the treatment, even the older and the elderly MDS, high-risk MDS and leukemia patients. So perhaps that could be the midway to get to the point of debulking the disease and going on to get a transplant.
So a lot of data to support not doing intensive Ara-C daunorubicin-based treatment for MDS, or high-risk MDS, even with excess blasts, and that the toxicities are much higher, and treatment-related mortality is much higher than with the hypomethylating agents.
Mm-hmm. I mean, I think that as I think I concluded at the end of my talk, that new ways of delivering patients in better disease control are clearly needed, and we can't underestimate the cumulative impacts that our patients go through when they have remission induction chemotherapy. The question, I think what we started off was saying that getting these patients to transplant is the goal. Getting them through transplant in order to enjoy the benefits of transplantation is the goal, and avoid anything that impairs that goal by excessively treating and making our patients excessively burdened by comorbidities should be avoided.
I think one of the things that I would like to underline what Dr. Lalit had initially commented on, that if somebody, I know that Vikram, we gave you a topic you may not necessarily agree with, but if somebody hits the door with a brother or a sister who's 100% match, in the current economy, not economy, but the economics of getting Vidaza or Revlimid in combination, or even getting 7+3 induction or any kind of chemotherapy, would it be actually harmful for the patient to delay that and then, get neutropenic fever, get fungal pneumonia, as opposed to a relatively healthy protoplasm who's walking through the door?
So, as Dr. Chapter has been saying, there's really no data for most of this. A lot of this is opinions. I would still go. A 15-18% blast, a person who is 30, looks absolutely well, no comorbidities. I would probably attempt to achieve remission. If they didn't have resources, if they had no resource constraints, I would probably go with a hypermethylating agent. If not, I would go with a 7-3. But where do you draw those lines? At which point do you stop and say this is not practical? Is difficult. But clearly, there are patients who will do badly with this approach, and hypermethylating agents are expensive, so that has to be kept in mind. Not everybody can afford them, and you have to give multiple cycles of it, and that requires its own support systems. So one has to trade off at some point and say, I would go for transplant straight away. But I don't have those lines defined that clearly. It goes on each case. And I think one point that Dr. Ritchie made, which is very important, is all these patients are not the same. Some of them, the kinetics are very different. Some of them will progress very rapidly in front of you, while some will just linger on. And I think all this has to be taken into account when one decides on what type of intervention. Same thing, sir, but that's what I'm saying. I would, in a young person, absolutely no comorbidities, looks very well. I would consider inducing remission.
So a common situation is you got somebody you think is in first remission. You're getting ready to go. You do your bone marrow right before the transplant, and lo and behold, there's 30% blast. And so the question is, well, do you just keep going and doing the transplant, or would you say, well, we're going to refer them back for more chemotherapy? In our hands, we usually just go ahead and do the transplant, because at the end of the day, we think that we probably would save more people by that measure than giving induction and having some people get worse and a small fraction going into remission.
What if that bone marrow was done 3 months after their initial presentation versus 3 years after their initial presentation? So very early relapse versus late early relapse.
Yeah, so the chance of getting a second remission is related to the time you're in first remission. And if you're in remission more than 1 year, you have a greater than 50% chance of getting a second CR. If you're less than 1 year, that's more like 20%. So if it's an early relapse, we would be much more inclined to not do more chemo and just do the transplant than if it's a late relapse. Okay, I think we've thoroughly discussed the topic. So we'll adjourn. Actually, I guess we're having the lunch. What's the logistics of lunch? It's outside? Okay. Sir Paul is going to tell us about lunch. Thank you.